My name is Fermin García. I am honored to be participating in the 2021 version of the Prague workshop on catheter ablation, and I thank the organizer for allowing me to be part of this wonderful program. I was asked to discuss coronary venous mapping for PVC and ventricular tachycardia. The left ventricular outflow tract, it's a very interesting portion of the heart, and it's a perfect example to the importance of understanding of the 3D anatomy of the human heart. And when I talk about 3D anatomy specifically, we need to understand that there isn't any structure that we're mapping in VT and PVCs, endocardial, an intramural, or an epicardial component. A perfect example for this is the left ventricular outflow tract. In this image, we look at the left ventricular outflow tract three-dimensional anatomy. The most epicardial aspect, the left ventricular outflow tract, is the so-called left ventricular summit or LV summit. When we focus on this area and the yellow arrow representing the LV summit, we can understand if we have an arrhythmia coming from this segment of ventricular tissue, there's going to be different possibilities on how to access this area. The first would, of course, be the epicardium, so an arrhythmia that is subepicardial origin or closer to the epicardium, the so-called true LV summit, could be ablated from the epi. However, the coronary arteries, as example in this anatomy picture, and the fat around them are limiting factors. So we use the veins that run next to it, the great cardiac vein, the AIV, to try to target this. In very close proximity is the insertion of the left coronary cusp in the top of the LV ostium and the junction between the right and the left coronary cusp, the so-called right-left junction. You can access this from below the left coronary cusp and directly target the left ventricular ostium of the outflow tract from the endocardial aspect. And then what we recognize and others is that there is the ability of using the heart anatomy and the heart venous and arterial system to map the intramural segment. So you can see here, for example, in this area, you have a first septal arterial perforator. And you have here these perforators that go down on the septum. And behind these septal perforators or next to them, there usually is a venous branch. So you can do either venous or arterial mapping of the septum on the intramural aspect of the left ventricular outflow tract. We prefer to map the veins because they're forgiving and not as the arteries that if you would cause a dissection, you would have a catastrophic complication. So when we take these pictures and moving forward, our techniques mostly focus on left ventricular venous mapping through the septal venous perforator. You can access this from the opposite side. This is the relationship between the pulmonary valve and the pulmonary outflow tract and the right ventricle to the top of the left ventricular ostium, and that's why sometimes ablation from the right ventricle helps for ablating, targeting rather arrhythmias that are coming from the top of the left ventricle. So the whole point of my presentation, including venous mapping, is to create a strategy that finally, in a more rapid form, directs our attention to define a best target of ablation and define if this is a patient that we can target from the endocardium, if this is a patient that we start to figure out how to go for the epicardium, or rapidly decide if it's neither one, endocardial or epicardial, and the origin of the arrhythmia is really intramural, in which case you have to define your ablation strategy either from the endo or the epi, even though it doesn't come neither from the endo or the epi, because at this point in time, we don't have any tools to ablate intramural arrhythmias. So in order to do this, we always start with accessing the venous system. And we routinely do this in every patient. I get access to the coronary sinus with a long sheath, either an Agilos or a LAM 90 or any other steerable sheath commercially available. The whole idea of using a larger sheath is that you can fit more than one catheter or more than one mapping strategy, and that you can exchange this for a catheter ablation if you decide to ablate there and you already have a conduit to get there. Everything starts with a good venogram. You can see here the Agilos sitting. I guide it over a wire all the time. I don't put an ablation catheter or anything different. And then with a forceful injection and a manifold of contrast, we can delineate the whole venous system. And you can see the AAV, the gray cardiac vein, and several septal venous perforators. After that, we can map the AAV and the gray cardiac vein. We withdraw that and put a selective cannulation tool. In this case, it's a Terumo glycas for French. And then we engage the septal perforators. You can see here an RAA shot, and you can see here an LAO shot of a venogram of the septal perforator, in which clearly shows that this goes down and septal in the heart, and we're talking about a septal branch. From there, we are able to place multipolar catheters. This selective cannulation represents placing of a 2 French octapolar catheter and bipolar mapping from this area of inside of the ventricle. We will then have direct information about epicardial activation through the AAV and the gray cardiac vein, and intramural segment through the septal perforators. And we use this strategy for every patient. So the idea is that if you have a patient with a PVC, classically represented in this example by a left ventricular outflow tract PVC, it's a left bundle with some transition in B3. There's a differential diagnosis for this, but take my word for it, this is somebody that was not coming from the RVOT, it's coming from the LVOT. We place the mapping catheter as described in the first septal perforator, and that's the LAO representation, and we record the signals. In this case, it's an octapolar catheter. Pole 1 is deeper on the septum. Pole 8 is closer to the annulus on base of the left ventricular ostium. You can see in sinus rhythm, which is very curious, the first thing we start seeing is, are these normal or abnormal signals? And we have published on this in the past, and you can see here classic slow conduction and lay potentials probably represent some level of fibrosis in this area. And then during the PVC, we obtain activation. In this case, the earliest activation is in pole 3, 4, right here on the top of the intramural aspect before it becomes the top of the left ventricle. We reconstruct the anatomy, in this case, using inside precision, so you can pull back and forth that octapolar catheter, and you can create this anatomy. And when you create this anatomy with this catheter, you create activation maps. In this case, we find the earliest activation deep on the vein, and from there, it goes towards the epicardial distally and proximally. So the whole concept is understand the EKG, get your catheters in place, and perform activation map as a first step of the epi and the intramural space. So you can see here a duodeca catheter in the AIV gray cardiac vein, and this is a wire, so you can use wires, so you can use multipolar catheters. This is in the first septal venous perforation, and this is the ablation catheter in the endocardium. So when you look at this, based on the available cardiac anatomy, you have access to 3 dimensions. You have epi, you have endo, and you have the intramural space. You can see here the activation pattern for this in sinus rhythm, and you can see the activation pattern for PVCs. In this case, the ectopy was earliest in the endocardium after guiding the mapping from the earliest side, which was earlier on the wire intramurally than the epicardium. And by placing the ablation catheter to the next area and doing map, you find the best area, and you can see here with intracardiac echo ablation in the earliest side. So you could argue you can do this case without the need of venous mapping, because if you had mapped this endocardially only, you would have had the earliest activation point and you didn't need any of this. And I probably would agree with you, for this particular case would not have been useful. But what about the tough cases, like for example, the so-called LV summit? Is it really LV summit? Well, the strategies varies. If you have something that comes from here and is closer to the endocardium, like the patient I just showed you, ablation from the endocardium is going to work and there is no problem. But what if it comes closer to the epicardium from the intramural space, and your site of origin is suggested by the differential timing between activation from the great cardiac vein to the endocardium, and then you try to ablate this from the endocardium and it's not going to work? Well, this is the perfect example for that. This is a case we performed in which we created the type of activation that I was explaining. You can see here the earliest activation is subepicardial, and from the subepicardial space, it goes to the epicardium and the AIV and the great cardiac vein, and then goes deep into the septum. The activation pattern is from proximal to distal. Okay, so this case, it's probably something that is closer to the epicardium, and from there spreads centrifugally into the septum and into the rest of the heart. So the approach is, well, we didn't want to start in the epi. We're going to try to approach from the endo. So we're going to put our ablation catheter close to the closest area, in this case, the proximal poles. When we look at this, the signals in the ablation catheter are super late compared to the earliest signal on 7/8. But we have described and others that if the distance between these two catheters is less than 1.2 or 1.3 centimeters, an ablation lesion from the endocardium could affect the intramural space or the subepicardial space. So we decide to ablate usually, as described here, starting on this area. You can see here in intracardiac echo, this is the LVOT, the left atrium, and you can see the catheter very, very basal, opposite to the actual duodeca catheter, who is coming down here and the tip being on the septum. And a lesion here didn't eliminate the PVC. However, when you pay close attention to the morphology of the ECG, V1 change. So you have a change of the exit of the PVC. Now, of course, this is the case that you know that ablating more from the endocardium is not going to be useful, and you have to direct your attention to the epi, and we do that by placing a catheter in the AIV great cardiac vein junction, and at that spot we get a -35, -40 milliseconds early signal and ablation from there. If you're far away from the coronaries, after confirming that with coronary angiography, it works fairly well. So usually these are cases that you need to sandwich your lesions from both sides and try to get the best information you can. Well, you can come and say, well, I still need venous mapping, etc. for this. So it takes us to this case, and this is, I think, the realization. In our series at this point, 10% of failed PVC ablations have this pattern. This is another case of a left ventricular outflow tract PVC, similar thing, a little bit of pattern break on V2. And we have here activation in sinus rhythm and activation with the wire. So what we have decided to do is to perform full activation of the endocardium, the venous perforator, and the epicardium. And you can clearly see here now a completely different pattern of activation. This is not endocardial to epicardial. This is not subepicardial to intramural. This is intramural early, where this electrode sits 1, 2 on the duodeca, and from there spreads out to the epi and the breakthrough to the endocardium. So there was no way you could have defined this by mapping the endocardium or mapping the epicardium. So the high utility of venous mapping comes from utilizing this technique to find the earliest site of activation. So in this case, the earliest site of activation for this patient PVC comes from this area, and this is the activation map for that. I want to guide your attention to the location of the catheter in intracardiac echo. This is the RVOT, this is the LVOT, and this is the catheter tip in the septum. So we guide our ablation catheter and put it opposite to this area, and that's where we map. Okay, fluoroscopically, next to the first pole, in eyes, LVOT next to that bright area, and here we record a signal that is late compared to the duodeca catheter, sorry, to the octapolar catheter, and it's late in the endocardium. It's after the QRS. Would you ablate here? And do you think it would be successful? And this is the whole point of this technique. You have identified the earliest site of activation. You are inside of the muscle. It's going towards the epi and then going towards the endo. So the whole point is to fluoroscopically and with intracardiac echo guide your ablation catheter to the earliest site of activation. You had never guessed that you were going to be successful in this place, because if you place your catheter here in the endocardium was late. You can see here, opposite to the earliest site of activation, we're very close to that, and we perform ablation here. And this is the lesion that you create. You were late. I remind you, you were late on the ablation catheter. And you can see here, we go on ablation and the PVC goes away. So I think this becomes very valuable, because if you do this routinely, you will identify the best site. And even when you thought you were going to get nothing early, because if you think about it here, if you were just mapping the epicardium, which is 5, 6, or 7, 8, it's late, because it's coming from inside to outside. So the big value of this technique is to identify intramural site of origins and create a strategy to map these arrhythmias. So anatomical characteristics are essential. It's not all epicardial if you fail. I think that what you are able to recognize with venous mapping is different pattern of activation, which means different sites of origins. And then by doing that, you define your best site of ablation. I believe that the success for ablation is better mapping and not more powerful or bigger procedures. You need to map the endo, the intramural, and the epicardia components of the LVOT. And based on that activation pattern, you design an ablation strategy based on the identification of the earliest site of the arrhythmia. You start endocardial, of course, if it's early in the endocardium, or you start endocardial if it's early intramurally in that first septal perforator, by placing your ablation catheter anatomically opposite to the earliest site, and you ablate there even though you're late in the endocardium. If you're early in the subepicardial area, and it's a true LV summit epicardial PVC, and the distance for that catheter is not that far away, you may be able to do it from the endocardium. You go to the epicardium from the AIV or the great cardiac vein when you, of course, fail endocardial ablation because you were too far away, or if you're truly located in the subepicardial space. And that usually represents an activation time of -35 or -40 in the AIV or the great cardiac vein. Here you find high impedance, you have to modify the system, you may use half normal saline, which might allow you to deliver a better lesion. You also go to the epicardial when you ablate it in the endo, and you notice that you have a change on the morphology of the 12-lead EKG, and you change the exit towards the epicardium, so you can go and then target the epi. And in case of failed procedures, I think this is a useful technique to guide your anatomical understanding, to provide options like bipolar ablation. If the veins are small or you want to do multiple balloons, you can consider alcohol ablation. And I think you leave for last for true epicardial arrhythmias that are anatomically not suitable to ablation from the great cardiac vein or the AIV because of the location of the coronary arteries. You leave for those cases consideration for surgical procedures, either thoracoscopically or open minimal invasive procedures. I hope this is explanatory of our technique for venous mapping, and I once again thank the organizer. I'm honored to be part of this program, and I hope that next year we will be in person in Prague, and I wish the organizers and my colleagues the best success with this meeting. Thank you very much.
Thank you very much. I will be discussing today our experience using alcohol ablation for ventricular arrhythmias. This has been just recently published as of October 2020 in JACC, where we compiled the entire experience of 12 centers and 63 patients with ablation refractory ventricular arrhythmias, both PVCs and VTs, mostly from the LV summit, 48 of them, but also from other regions. And the approach was common to both. We would map endocardially the left ventricle and the right ventricle, and if indicated, the epicardium. And then we would do cannulation of the coronary sinus and map the coronary sinus and its branches, usually the anterior interventricular vein. We would obtain venograms, and then we would select for targeting intramural branches of the coronary sinus wherever the earliest activation time would be. And then once we select a branch, we would wire it and then deliver a balloon and deliver alcohol. All in all, we had 48 LV summit PVCs or MDTs, and the strategy was similar for non-LV summit as well. I will focus mostly in the LV summit data. Like I said, it was 48 cases, and it's important when we target the LV summit venous anatomy to understand it. And this is what actually has been hardest for me to come up with a set of fluoroscopic views and that demonstrate the anatomy and to actually understand the anatomy. We actually don't use this schematic, which is kind of overly simplistic, especially because it's not very helpful fluoroscopically. In LAO caudal, the LV summit veins can be divided as an LV annular vein that arises from the great cardiac vein, and then septal branches that go to the right of the anterior ventricular vein, and diagonal branches that go to the left. And in RAO, they are actually quite overlapped and it's hard to interpret. So this is an example of an LV annular vein. This is coronary sinus venogram. You see the great cardiac vein is here, and this is the LV annular vein where we could put a balloon and a wire, and then we would map signals, configuring the wire as a unipolar electrode, and then we would deliver alcohol if indicated, as shown here. And once we deliver alcohol, we like to inject contrast to see the staining and see where the alcohol is going. The in about cases, only 5 of them were actually harboring the arrhythmogenic substrate. So only 5 out of 48 had annular veins targeted with alcohol. And usually these veins will have atrial and ventricular signals. More commonly, we would use septal veins for targeting LV summit arrhythmias. The septal veins were defined as those that arose at the origin of the anterior interventricular vein or later on in the anterior interventricular vein. They would be close to the left main coronary artery, and they may have retroaortic branches as shown here. And this was the most common targeted vein. If you can see in 3D mapping, when you put an octopolar catheter in this vein, you'll see how it is right at the LV summit below the veins, the AIV here, and between the LV outflow tract and aorta, and here is the left main coronary artery. So it really is a nice vein to target the inaccessible LV summit. Other veins that we targeted included septal veins, more distal into the AIV, like this one, and diagonal veins in cases of very angulated coronary sinus. But when we gave alcohol, the interesting thing is how much tissue is getting affected. And that's kind of a weakness of this technique. Well, we get an idea as to how much gets affected based on how much tissue gets stained. And acutely, you can see, this is one example where we targeted the septal vein where we got the best signal. You can see here very early relative to the QRS, and right between the LV outflow tract and the RV outflow tract, so in a perfect location. When we gave contrast after alcohol, you see immediately echogenicity on ice, and you can actually sound it on cartosound and incorporate that echogenic area into the map. And it's beautiful because it shows how truly intramural the alcohol ablation is. And you can see an estimated area of alcohol reach is by the sounded echogenicity area. You can see how it's between the LV outflow tract and the RV outflow tract. And you can see in LAO here, LV outflow, RV outflow, and right in the middle is the echogenic area as we sounded it with cartosound. We can also get MRIs, and on MRI is very interesting because what you get is the opposite of gadolinium enhancement. What you get is zero gadolinium, so it's called microvascular obstruction. There's no gadolinium penetration, and you see these dark areas. And this is how we get an idea of where the alcohol goes. We've used this technique in lateral veins in ischemic VT as well. And it's very interesting because you can target very large areas of tissue with alcohol. Now, how would you target a large vein like this one? This is a huge vein where we were able to put a decanav catheter and make it part of the map. And you can see how it's on the epicardial aspect of this endocardial scar. We advance an octapolar catheter in this vein, and then we can actually, by entrainment maneuver, show that these signals are in the VT circuit, the epicardial component of the VT circuit. You can see the vein in the map by tracing the octapolar catheter in the cartomap. And to target these large veins, what we do is this double balloon technique. By the double balloon technique, what we do is we put two balloons separated by about 2 centimeters, and both of them occlude the vein. And what we do is we inject alcohol through the proximal one. So we trap the alcohol in between the balloons and we force it to go into each of the branches to reach intramural targets. And what we do is then we move the two balloons sequentially from distal to proximal and deliver alcohol in each kind of step. And that way we achieve a large area of alcohol-induced ablation. You could criticize this as being a massive, too aggressive ablation, but when you have endocardial scar and the epicardium is just showing these signals that are mid-diastolic and scarred, they are legitimate targets. This is another example of the infarct-related vein, a patient with a massive inferolateral infarct with a left ventricular assist device. We cannulated this massive posterolateral vein, huge vein, as you can see here. We put a decapolar catheter in the vein. We showed by entrainment maneuvers that we were mid-diastolic by looking at those signals from the epicardial venous catheter. And then we use the same approach, a double balloon technique. In this case, we use from proximal to distal, 2 wires, 2 balloons, and then we give alcohol from the proximal balloon at different stages in the vein, from proximal here, balloon 2, balloon 1, balloon 2 here, balloon 1, and then we go more distal. And as you inject alcohol, you see the echogenicity grow. Bottom line here is that for every infarct, there's an epicardial vein, and we can do this in lateral veins, in the anterior interventricular vein, and others. You can see sometimes incredibly late in the epicardial. We are doing some studies looking at what happens to the alcohol when given with the double balloon technique, and we see acutely, like I said, echogenicity develop kind of immediately. And on MRI, you see this microvascular obstruction phenomenon where you see darkness. This is within 24 hours after alcohol delivery. What happens to that microvascular occlusion long-term? What we see is that it can get replaced by scar. This is an example of 24 hours post-ethanol. You see these patches of dark areas where the alcohol was given and there was microvascular obstruction and no penetration of the gadolinium. And at 30 days, this becomes a full scar with a brightness as shown in the delayed enhancement. All in all, we have experience now. This is what we reported, 63 patients enrolled. 7 of them had no suitable veins, so this doesn't work for everybody. But of the 56 patients that got retrograde coronary venous alcohol, in 1, there was no acute effect. In the other 55, there was acute success. Now, mind you, these patients, we need to observe and we need to give isoproterenol and see if there's recurrence. And we like to reinforce the ablation with concomitant radiofrequency in the alcohol targeted areas. But all in all, we achieved a success rate of 76% after 1 year in patients that had failed sometimes 4 ablations before doing the alcohol. So we conclude that venous ethanol can target intramural focal sources, LV summit and others. We can obtain a large tissue ablation with the double balloon technique, particularly when used in infarct-related veins. Most commonly, we've used it in laterals, but also in others. Alcohol leads to microvascular occlusion detected by MRI acutely, and then it is replaced by scar. The venous anatomy is challenging and variable and determines the acute success and the chronic success of alcohol. But using it, we have shown that we can achieve success of up to 76% at 1 year of follow-up. So that concludes the presentation, and then we'll go on with a recorded case. The case was a 54-year-old woman with recurrent palpitations. She had been a previous marathon runner and had developed palpitations for 3 years and had failed an ablation twice elsewhere. Okay, so we are mapping and ablating today a previously failed ablation of LV summit PVCs, and we have access in the perifemoral vein with a 10 French sheath for eyes, an 8 French sheath that we're going to use now to map the RV outflow tract with the pentarray,
And we have a preface sheath that is engaged in the coronary sinus, where we also have a decanal catheter in the coronary sinus, as you can see in the map. We have already activation times in the AIV DCV junction. That's where we have the earliest, 28 milliseconds before the QRS, right at that junction. So before we do anything else, we're going to map the RV outflow tract, and then the LV outflow tract. And then
so that's the usual sequence. We would get a decapolar in the AIV, where we had an earlier signals 26 milliseconds, and the pace map was acceptable, 79%. But before we jump into giving alcohol, we like to complete the map with RV outflow maps.
So now we've completed a map of the RV outflow tract, and nothing is as early as in the AIV origin. So as the earliest in the RV outflow is the most septal aspect of the RV outflow, but it's not as early as we have now completed a map of the LV outflow tract in the cusps. You can see in the RAO we're mapping with the pentaray. No, go a little bit to the left. We went retroaortic, got one artery, which is a very helpful thing for anatomy friends. The earliest in the LV outflow tract is immediately below and septal to the left main coronary ostium. That's a signal. Immediately deeper in the LV outflow tract, signals get later, and then maybe perhaps a little bit earlier, right underneath the earliest site in the AIV, but the AIV site remains the earliest.
So now we justify targeting the veins, because we have shown that both LV outflow and RV outflow are later than the AIV. So the idea is to find a vein branch that is in this neighborhood between 2, 3, and 4, 5 electrodes of the decanal.
You can do it. Okay.
Go ahead.
So this is taking a reference, Misha, or someone record this on ice, of where the area.
So we like to see on ice how echogenic the muscle is in the area of earliest activation as a reference. So you can see here a little bit of RV outflow tract, the muscle of the LV summit, something somewhere like here. And you see this appears like completely indistinct muscle. You will see later after we give alcohol how that looks. So we do venograms. We put a sheath as a Park sheath in the CS, and then we have here a JR4 catheter, and we give contrast injection to see what kind of veins are there in the location where we had the earliest activation site, which was somewhere in here in the AIV, very proximal AIV. And here we have a octopolar 2 French catheter engaged in a septal branch where we can do pace maps and collect signals. And that was actually quite acceptable there. Let me show you the specifics of the timing there.
So we have engaged the AIV with a small catheter, a 2 French octopolar catheter, and we found the distal end is engaged in what we think is a septal branch, pacing from the distal octopolar there, we get 97% match. Go real-time analysis.
So it was 97% match, as you can see here by the Carto, the Paso software. But if you look carefully, V2, there's an R wave in the natural PVCs, and we don't have an R wave in the pace beats. And the activation time there was not perfect. This just shows you in real-time video the location of the octopolar distal catheter in a septal branch. It was very close to the earliest activation as detected by the decanav. But this is, you don't like to settle for the first one you see, and we thought we would look further.
So we have engaged the AI pre-aortic branch. So okay, we have been mapping different branches of the AIV. We just found one very early septal branch that, as you can see there, is between the left main and the AIV, and it goes deep intramural there between the LV outflow tract and the AIV.
You can see here, this was just by maneuvering the octopolar catheter, we got into an earlier branch. The signal here preceded the QRS by 44 milliseconds. So this is much better. It's unusual. It's what was unclear here is where the anatomy, where this vein was taking off. And then, so for that, we need to understand better the anatomy. And what I want to illustrate here is the value of RAO versus LAO. In RAO, you don't know, this is all for shortened. It's very hard to understand where this catheter is. It's actually easier to see it in 3D in the carto map. But what we do is do other venograms. And this is important to emphasize the value of LAO caudal. The LAO caudal is the view that interventional cardiologists use to see the left main. Well, where is the left main? The left main coronary artery is in the LV summit. So the LAO caudal is the best view to understand venous anatomy. And here you can see how there's a big vein that appears to take off early. We call this the annular vein because it's a branch of the great cardiac vein and not of the anterior interventricular vein. In RAO, it's completely foreshortened. You don't see where this is going. It's just overlapping with this bunch of all opacified contrast. So it's very hard to understand in RAO, but in LAO caudal, you can see it very well. And this is the location of the octopolar in that perfect view. The pace map now is perfect. It's also gives us 97%, but you can see how now we have R waves in V1 and V2 that we did not have before. And then when we see the signal here, it's 44 milliseconds or 45 milliseconds before the QRS. The pace map is perfect. And this is the location of this Baylis or octopolar 2 French microelectrode. You can see 1 and 2 here is where we're getting the best signals. So the next step is, okay, let's put a wire and a balloon in here. And also we need to, before give alcohol, understand how big this vein is.
Carto tracking the location of the wire by that number 1 is a little bit more medial or septal than where the AIV than with the octopolar catheter was. So I don't think I want to take this.
So what we were doing here is we tried to, so we got the wire and the balloon in that vein, and then we need to understand, we need to get signals as good with the wire as they were with the EP star. And the first thing we see is that this vein is very big, and perhaps we don't want to give alcohol in it. And as you can see here, the wire is not truly in the lumen of the vein. It's taking a smaller branch. Let me just, you see that here. You see that? I'm not inside the lumen. The lumen is here and this wire is out. So we had to reposition that.
All right, so we have come out of that initial branch. We got back in the main branch of this septal annular vein, and we're sampling from the distal part of the wire. Pacing there is giving us a 98.5 or 99% pace map. On Carto, you can see how it's right underneath the earliest signal that we had in the AIV. That's a more suitable target.
So this is where this wire is in 3D projected by the Carto. And this is the perfect pace map that is similar to what we were getting with the EP star. But because this vein was big, we chose to do a double balloon technique to block the alcohol in between the two balloons and prevent the alcohol from going into undesired location. So this is what we did here. We have one wire, one balloon, and then I am trying to get here with a second wire. It's not always straightforward. And then there it goes. The second wire goes in, and now we have 2 wires, 2 balloons. And the idea is we want to collect signals. The idea is that we have the perfect location is in between the 2 balloons. So the wire proximal here will give us our targeted area. I want you to appreciate also the complexity of the anatomy. This is in LAO caudal, where we kind of see where we are, and in RAO, we can't understand anything. Everything is overlapped. But also we have the luxury of 3D maps. So this red catheter here is the wire, is how Carto represents the wire, and in gray is the previous location of the EP star where we were getting those beautiful signals. So what kind of signals can we get from the wire? Well, you can look at them here. Perfect pace map. You see, completely identical to the PVCs. The signal, the unipolar signal, is 40 milliseconds before the QRS. If we use the proximal wire in between the two balloons. Now, if we look at the distal wire, it was pretty good too, but we were getting 30 milliseconds. And when we pulled the distal wire out and injected alcohol, we saw how there's these deep septal branches. We do not really want to give alcohol going deep into here. So it confirmed that we really wanted to use the two balloons, block distal flow with the distal wire, and inject alcohol in the proximal wire and sequester or block the alcohol in between the two.
Two balloons inflated now in the vein of interest with the plan to give alcohol in between the two balloons and injecting contrast through the proximal balloon. See the staining?
You see the staining here?
All right, let's get the alcohol.
So then we give alcohol using slow injection, 1 cc over a minute, and then we repeat that. We want to give a solid therapeutic effect, and for that we need alcohol repeatedly. I want to show you how it looks as we give alcohol, and this, you get the myocardial staining, and on intracardiac echo you see bright spots showing up in the intramural LV summit muscle. So this is a view from the catheters in the RV outflow. This is the aorta. This is the atrial appendage. Here, muscle of the LV summit. Echogenic.
So we have delivered 3 injections of alcohol. We thought there was some shunting between the two balloons in undesired veins branches. So we have advanced the proximal balloon closer to the distal. You can see already some echogenicity in the area we ablated. There's right areas there. We are in RAO. Let's see. All right, the two balloons.
So it's very common after several injections that the alcohol kind of gets extravasated and you see more staining that you would want to. This kind of staining is outside the myocardium. This is probably an epicardial fat that contrast has leaked. We know the therapeutic effect is concentrated between the two balloons. And this is the way it finally looked after giving 4 injections. And on eyes, you can see a very distinct echogenic area where alcohol has reached the tissues. Now, this appears a bit scary, but then the actual myocardial reach is totally acceptable. With that, during alcohol, we saw.
And now we're testing.
She had a run of ethanol-induced VT during alcohol injection. That's very common.
Reproducibly induced PVCs with epinephrine boluses. We just gave her 1. Is that it? Constant. So she transiently developed right bundle. There's 1 PVC fused. She transiently developed the right bundle branch block, and then it went away. Then we'll see if we have any doubts. What we will do is ablate in the adjacent areas to kind of complement what we have achieved with alcohol.
So during alcohol, there was a transient thymectopy, and then right bundle branch developed, but it resolved spontaneously. As you can see here, this is right bundle going away. And what we like to do is reinforce the ablation with ablation by proximity in the RV outflow and the LV outflow.
So we are now touching up the ablation to complete the job from the right side. You see the echogenic area deep in the muscle there. We chip with alcohol, and then I'm ablating adjacent to it from the RV to complete the job. We are reinforcing the ablation from the LV side. We have the ablation retroaortic, and we can see on eyes. We see the ablation catheter. It is there next to the echogenic areas that we obtained with alcohol. So the idea here, we're going to ablate somewhere.
So the idea is to someone that has had 3 ablations, you want to have this procedure succeed and be the last one. So as much as I believe in alcohol doing the job, and I think I like to target a signal that is 45 milliseconds before the QRS as opposed to a mediocre signal in the neighborhood, I like to reinforce it too. There's no point in being dogmatic here. The idea is to get success for the patient. We did an MRI 24 hours after, and there was some myocardial edema and microvascular obstruction as shown. This is kind of, you can see this was outside. This is kind of fat between the appendage and the LV base. The true myocardial alcohol delivery was here. You can see how you get a transmural lesion in there. So that concludes the case. This patient was done a month ago, and she hasn't had any recurrence, and she's very happy after 3 ablations, but we got the job done. Thank you very much.
Hello, this is Pasquale Santangeli from the Hospital University of Pennsylvania. I wish to thank Professor Kaltzner for the kind invitation to this meeting, and the topic that has been assigned to me is to summarize the role of multi-electrode mapping in catheter ablation of VT. To this purpose, I will summarize what I believe are the major benefits of multipolar mapping and will concentrate on few concepts related to mapping the substrate in sinus or pace rhythm, discussing the value of improving the resolution to detect the abnormal substrate, improving the density of collected points, and allowing for an overall faster mapping. When mapping in VT, multipolar mapping has benefit in terms of density and resolution to visualize the diastolic pathway and also facilitate entrainment mapping. Finally, something that is very important for substrate-based ablation strategies, a better definition of the ablation endpoints with an assessment of the ablation effect on the near-field electrograms, and allowing for a fast remapping to quickly validate the efficacy of the substrate-based ablation. Let's start with mapping the substrate in sinus or pace rhythm. There is no doubt that multipolar mapping has made substrate mapping significantly faster compared to point-by-point mapping. Here you can see mapping with a multipolar grid catheter, and you can appreciate the number of the electrograms over a wide area that are simultaneously acquired. In this case, in about 30 minutes of mapping, we obtain a complete substrate map of the left ventricle, including more than 10,000 points. And here you can see also the nice display of a wide area covered in the ventricle of the substrate with abnormal electrograms. Now, the conduction velocity is a major determinant of voltage. And if you directly compare the standard linear mapping catheter and ablation catheter, which is typically a 3.5 millimeter tip electrode, these are significantly larger than the electrodes that are mounted on a multipolar catheters. If a standard ablation catheter is deployed in an area of scar with a surviving myocardial bundle, this is a larger area will be all recorded simultaneously with an overall smaller conduction velocity. A smaller electrode here on the bottom with a tight interelectrode distance may be able to record only the small area surviving myocardial bundles and display ultimately a normal voltage characteristics. This concept has been investigated quite extensively in preclinical models. Here you see a standard voltage map performed on the left side with contact force ablation catheter, and on the right panel, the same map, and the same day, of course, performed with a pentarate catheter. You can appreciate the significant differences in local voltage recorded with the two catheters here, as you can see, in areas where the thermocool catheter showed otherwise low voltage. Here, the same area with 14 grams of contact, you see low voltage bipolar and normal voltage with a pentarate catheter. I have to say that in clinical studies and a clinical experience with these catheters, I have seen differences going both ways. This is an example where the standard thermocool catheter showed relatively preserved voltage, whereas mapping with a pentarate disclosed lower voltage with a higher degree of fractionation. And this difference really depends on the, I would say, in whether you have a dense scar versus a layered scar that is only located in the subendocardial tissue. You can go either way. You can either display higher voltage if you're mapping surviving bundles within the dense scar with a pentarate, or even lower voltage if you're just looking at the layer of subendocardial or subepicardial scar in otherwise areas of preserved voltage right below the subendocardium. Similarly, in this example, where the same map was performed with two different mapping systems and two different catheters, on the left with a thermocool catheter and on the right with the Ryan catheter, The overall representation of the bipolar low voltage was different with a multicolor catheter, presenting a little bit lower voltages here, mostly at the level of the basal septum compared to what we see with a thermocool catheter. The angle at which the catheter is placed, the so-called angle of incidence, is also an important determinant of the local voltage. If you place a catheter now perpendicular here on the left side, here is a y-axis is a peak-to-peak voltage in bipolar, and the time to the second unipolar activation on the x-axis. But if you place your catheter perpendicular to the wall, the wavefront will be looked at each of the unipoles of that bipolar pair almost at the same time. And because of that, the difference, which is what a bipolar signal truly is, will be reduced. If you put now the catheter parallel to the wall and aligned with the longitudinal fiber orientation, the activation is rapid and the voltage increases. Finally, if you have the catheter parallel but perpendicular to the wavefront here, which is the bottom, the most rightward part of the graph here. So again, you are parallel but perpendicular to the wavefront. You will have abnormally slow conduction because of anisotropy, and the voltage will be reduced. So there's nothing to do with tissue. The tissue, the record is the same, but the voltage varies depending on the angle of incidence. And here just an example from our early experience with multipolar catheters. This is a map of an anterior myocardial infarction done with two different wavefronts, one in biventricular pacing and the other one with RV-only pacing. And you can appreciate the significant differences in local voltage recording in the same area. Again, the tissue is the same, the voltage changes depending on the wavefront of activation. And the reason why this is relevant for a multipolar mapping is there are specific catheter designs, such as here, the HT grid catheter, that present equally spaced orthogonal electrodes that allow to analyze the voltage characteristics relatively independent on the angle of incidence. Here you can see a case of inferior myocardial infarction. We present segments of relatively preserved wall thickness within the areas of wall thinning on CT scan. These channels were not appreciated with standard configuration voltage mapping, but they could be appreciated with this specific HD wave algorithm here that takes into consideration mapping from orthogonal bipoles and will definitely display on the highest voltage. So basically, it's relatively independent on the angle of incidence of the catheter compared to the wavefront of activation, relatively independent. These voltage channels can correspond to activation channels that can be visualized by changing the wavefront of activation. In this case, from sinus rhythm to RV apical pacing and quickly performing a remapping, you can appreciate two sides of breakthrough here. And again, we're looking at the apex from here, the RV apex yearly activation, and then the inferior wall is an inferior view of the left ventricle. And two sides of breakthrough can be appreciated within the scar, one in the mid scar here and one in more basal in the perimachular region. And again, they did correspond fairly nicely with the areas of relatively preserved voltage with the HT wave algorithm. Multipolar catheters have definitely also changed the way we map during VT. The benefits extend to an improved density and resolution of electrograms at the level of diastolic pathway, and also to facilitate entrainment mapping. So now, without doubt, the presence of a mappable VT represents a good day in the EP lab. By fair, I have to say, to be fair, these do represent a minority of cases that we see in our institutions, but whenever we see them, we try to map in VT as much as possible to define the diastolic pathway. Multipolar mapping in these cases greatly facilitated the fine definition of the full circuit. Here is a case of right bundle superior axis VT in a large inferior MI here. And again, by using multipolar mapping, we were able to define the entire diastolic pathway with the entire evolution of the VT around the perimachular region, kind of a figure of 8, and back in the center of the scar here. The enhanced resolution seen with substrate mapping applies also on mapping during VT. Here you can see mapping in the same site, which is in the perimachular region, in VT, the same VT with two different catheters. One is a pentary catheter, and the other one is a standard large tip ablation catheter, the thermocool catheter. And when deploying the ablation catheter in the same site, we see only very low amplitude electrograms and hard to discern diastolic components. But when we apply the same area, we sample the same area with a pentary catheter, then you can see a very nice delineation of diastolic activity that covers most of the tachycardia cycle length here. And similarly, in areas of preserved voltage in non-ischemic cardiomyopathy, we have found evidence of diastolic components during VT by mapping with a multipolar catheter as compared to the large tip catheter that otherwise doesn't display the same degree of electrograms, the same type of electrograms. A clear identification of the diastolic components may also carry some important prognostic value, as it has been recently been associated with improved ablation outcomes in this observational study by Paolo Della Bella's lab, in which the full diastolic pathway could be visualized with multipolar catheters by mapping, of course, in this case, it's an epicardial VT, mapping the entrance, the isthmus, and the exit by imaging the entire diastolic pathway. And the definition of the diastolic pathway has also been helpful to plan the procedural approach and possibly improve the outcomes. In addition to better activation mapping, having small electrodes with tight inter-electrode distance also allows for a more near-field capture during pacing or entrainment. Like in this example, where you can see orthodromic capture during entrainment of pretty much the entire diastolic pathway here, with concealed QRS fusion, the capture, the VT has been accelerated and perfect PPI. So again, having small electrode with tight inter-electrode distance helps also to capture the near-field electrogram components during entrainment mapping, and facilitates also, of course, measuring the post-pacing interval. Finally, something that I think is quite relevant to any form of substrate-based ablation strategist, multipolar catheters allow for an assessment which is quite objective of the acute effect of the ablation, as well as validation of the ablation endpoints. As you will see in this case that I will present next, our usual setup for scar-based VTs and when working with multipolar catheters is to have a dual access to the left ventricle, one to map the chamber with a multipolar catheter and the other access with the ablation catheter. This does facilitate the assessment of the acute assessment of the ablation effect on the local electrograms that typically can be recorded only some of those from the multipolar catheter. This is an example here. You see before RF radio frequency, high frequency components on the pentary catheter that are not seen on the ablation catheter deployed on top of it. And when we ablate, we have elimination of these late potentials on the pentary catheter, which validates the acute ablation endpoint. When possible, and particularly for cases of ischemic scar with multiple induced VT, we try to eliminate the electrograms within the substrate to achieve eventually scar isolation. And this can be validated directly with multipolar catheters mapping. In this case, scar isolation was achieved by targeting the earliest areas of activation at the border zone of the scar, and with the substrate, which resulted in elimination of the late potentials that are deployed within, from a multipolar catheter deployed within the substrate here, and is a nice way to prove at least entrance block within the scar. And of course, whenever you demonstrate that, you also want to make sure that it's also exit block when pacing within the area of interest here. And here we're pacing from the multipolar catheter, is a decanap catheter within the scar. We are recording local capture from the ablation catheter, as you can see here in the little arrows, but this local capture does not produce any QRS complex, which again shows that there is also exit block. And of course, you also validate here the entrance block with a native QRS with no late potentials. And also you see dissociated activity within the scar with no QRS production produced. It's very similar to what we've been observing for pulmonary vein isolation. But again, this can be achieved typically in patients with transmural scars and mostly in the apical region, because of course in the inferior region, you will not overcome the issues with intracavitary structures such as the papillary muscles, and it's more difficult to achieve. Now, I would like to highlight a major limitation with all these techniques that employ multipolar catheters to enhance the near field mapping resolution. A very large proportion of our non-ischemic cardiomyopathy population does have mid-myocardial substrate. And in these cases, multipolar mapping, which can only access the endocardial and epicardial mappable surface, is greatly limited, as it will invariably display normal voltage as well as normal conduction properties with no evidence of abnormal electrograms. In these cases, I believe the new catheter designs and new softwares with larger electrodes and wider inter-electrode distance may help to detect the far-field activity that may be relevant, particularly in case of mid-myocardial substrate. And the idea is very simple. If you widen the inter-electrode distance, you'll be able to cover and to record a wider area, assuming that both electrodes, of course, are in contact with the myocardium. In this case, we've been playing with this concept for a while now for septal VT cases, mid-myocardial VT cases, by enlarging the window of a recording from the most distal tip of the ablation catheter to the most proximal ring electrode. And again, this is a case where we enlarge the electrode bipolar distance of the standard thermocool catheter. And again, we were able to detect in the basal septum diastolic activity. As you can see here is as in green, you see diastolic far field components. They were not seen in the standard bipolar configuration in this basal septal VT. And ablation at that site resulted in the late termination of the ventricular tachycardia. Of course, one important limitation of this approach, you have to make sure that both the tip electrode and the most proximal ring electrode are in contact with the underlying tissue. Otherwise, you won't be able to see the far field activity. Now, the next 5-10 minutes I spent talking about this specific case and discussing this specific case, which is really a relatively simple case that does highlight, however, the way we approach and we use multipolar catheters in our current practice for scar-related VT. He's a 69-year-old gentleman with history of coronary disease and inferior infarction with a significant scar, as you can appreciate here on the echo images, plus a significant PAD with iliac stents bilaterally that we knew be up front. He had undergone a total of 5 prior PVC and VT ablations at 2 different institutions, including 2 endoepicardial procedures, and every current VT despite sotalol and despite amiodarone presented with ICD shocks. And thankfully, he only had one specific clinical VT morphology as determined by intracardial electrograms and cycle length of the VT on the ICD. The pain score for this case was 17, which is the highest tertile of risk. Above 15, 17 is considered the highest tertile and the higher risk of hemodynamic decompensation. In this case, of course, the presence of PAD prevented us from using a hemodynamic support device. And from a procedural practical perspective, this does translate into a specific approach, which is basically minimizing the amount of substrate mapping with only one wavefront. And typically we use LV pacing for patients with bad heart failure and low ejection fraction to prevent the acute decompensation effect from RV-only pacing, which we have seen occasionally. And also, now an important aspect, we do limit as much as possible VT induction. Pre-procedural substrate characterization was performed in this particular case with MRI and the in-heart software, which largely confirmed the presence of a large inferior scar and transmural scar. And of interest, there were some areas of the basal septum where the scar extended intramurally. We have been interested in identifying these areas from pre-procedural imaging, as these may not be easily identifiable with intraprocedural mapping, as due to the limitations that we discussed about. At baseline, we always start with a NIP study when the patient is not under anesthesia to evaluate the baseline inducibility and see whether we can capture the 12-lead ECG of the clinical VT by matching the intracardiac electrograms on the ICD and the cycle length. Here you can see the VT that matched the intracardiac EGMs, was inducible with program stimulation and double extra stimuli. We matched the intracardiac EGMs and cycle length of the stored clinical episodes from the ICD. And as expected, it wasn't hemodynamically tolerated and had to be cardioverted promptly. It is a right bundle bench block superior axis VT, which is compatible with the location of the abnormal substrate. This is quite important, as in our experience, there is a small but discrete and concrete proportion of inducible VTs in patients with structural heart disease that do not arise from the abnormal substrate. These can be focal VTs, can be Purkinje-related VTs, and we want to identify this group upfront before proceeding with empirical substrate modification that, by definition, will not take care of the clinical VT in these cases. Here you can see our approach with multipolar mapping. We typically limit mapping to the left ventricle for ischemic cardiomyopathy, but in the subset of patients with large inferior MI, as well as those present with clinical or inducible left bundle branch block VTs, I've been mapping also the right ventricle to make sure that potential RV portions of the substrate that may be relevant in some cases are not missed. As we mentioned above, for LV mapping, I always proceed with dual axis, one retrograde axis and transeptal axis. Occasionally, we do 2 transeptal for patients with significant aortic atheroma to facilitate mapping, but also to validate the ablation endpoint. In the bottom right here, you can see the sinus rhythm propagation map. I'm going to play it now. In this regard, a couple of things I want to highlight. In patients with biventricular devices, I tend to prefer to avoid mapping in biv pacing, which is a collision wavefront. We see the limitations before, and occasionally may be problematic to annotate timing, but also to see abnormal electrograms. In this case, to prevent acute decompensation, which was seen occasionally for RV-only pacing, we mapped with LV-only pacing by programming the RV threshold, the RV output as sub-threshold, and mapped with LV-only pacing from the CRT device. This propagation map in this wavefront didn't seem to show clear areas of conduction slowing. However, we always annotate manually the areas of abnormal late activity and lavas, and we can display it directly on the map as we move our catheter around to map and to proceed with our substrate mapping. Following substrate mapping, we review the propagation map to determine if there are areas of slow conduction and deceleration or isochronal crowding as identified on the island map. In this particular case and in this particular wavefront, we were not able to detect unequivocal discrete areas of isochronal crowding. The areas with highest density of abnormal electrograms are highlighted here in the bottom right. And again, these are manually annotated as we complete and we proceed with our map. We look at the electrograms ourselves and we ask the mapper to annotate the areas with highest density of abnormal electrograms. And again, these typically are manually annotated because it's not automatic software, at least in my experience, that will capture all of this. Next, we focus our attention on the areas of abnormal lead activity and best space match for the inducible VT that matches the clinical VT episode. And again, in this particular case, we position our multipolar catheter in this specific area of higher density of abnormal electrograms, and we perform best space match for the induced VT that we're targeting. And again, we perform another induction of VT in this specific area in order to identify the presence of diastolic activation in this specific region, which we proved in this particular case. Actually, we did cover pretty much the entire VT cycle length in this small area in the basal septal region of the left ventricle. Again, typically at this stage, we try to perform limited entrainment mapping whenever possible, but again, it's really, really dependent on the hemodynamic stability of the patient. Don't forget, it's a patient with a high pain score, was 17, and the VT was not hemodynamically tolerated. So in this particular case, we just report diastolic activation, we promptly calibrate the patient, and we then proceed with substrate modification in sinus rhythm. And again, the endpoint of substrate modification is always elimination of abnormal activity, abnormal electrograms of the areas that we're targeting. Here you see the abnormal activation in the basal septum, an example of late potentials here in the basal septum of the left ventricle on the left side. We target those potentials typically by looking directly at what happens to them by ablation of the periphery of the area of late potentials. And we're always watching the electrogram elimination on the multipolar catheter, as I explained before. And this after ablation, we see complete elimination of the abnormal electrograms. And here you see also near propagation map with the complete elimination of activation, near field activation in this specific region. Following this, we do extend ablation empirically to other areas of a higher density of abnormal activity, which was the most apical aspect, the apical aspect of the inferior substrate. And after that, we perform program stimulation again. We typically do 3 pulse and occasionally 4 extra stimuli to make sure that no VT is inducible following ablation. And that was the case in this particular situation here following ablation of these areas. At this point, the procedure is stopped after program stimulation has validated non-inducibility and elimination of the electrogram has been demonstrated with the mapping with a multipolar catheter. I will stop here and I thank you for your attention.
Mr. Chairman, ladies and gentlemen, thank you for your invitation for a Prague ablation workshop. This is my conflict. So, as we all know, if we want to target deeper substrates, we have basically 2 options when we want to use unipolar ablation. We can extend lesion duration or we can up-titrate powers. As we know, at some point there is not much gain, but at some energy levels, the risk of stim pop can increase. In a perfect world, we expect our lesion becomes uniform. This is because we expect our targeted area is of uniform resistivity. But unfortunately, in the real world, we frequently deal with situations when we have fibrosis, fat, and in such scenario, tissue will protect itself from radiofrequency current delivery, and our ablation lesion will be not uniform. So basically, what are the differences between different approaches? When we have classic unipolar approach, radiofrequency current goes from the tip of ablation catheter to a dispersive electrode, and here the density is so high that the lesion is created here, but not at the level of dispersive patch, which has a large surface. What we frequently do when we want to target a deeper substrate, we ablate from different spots in a sequential or simultaneous unipolar manner, but still ablation current goes from tips of these two catheters to a dispersive electrode, and we create two different lesions. With true bipolar approach, the ablation current goes from the tip of one catheter to another, and this results not only with transmural lesion, but also it generates more concentric, more cylindric shape of delivered lesion. So this can result in less collateral damage. So when not to think about bipolar ablation, it's difficult to offer bipolar ablation if we do not have consent from our patient, if he is asymptomatic. The pretty frequent scenario is when we experience a mapping error. So sometimes it's really to do remapping to map another structure, to use some kind of maneuver to reach the target. We also can experience a recurrence of different arrhythmia. This is not so rare scenario when our patient doesn't present clinical arrhythmia we targeted before, but he presents completely different VT. When site of origin is too close to crucial structures, for example, coronary arteries or his bundle, I think we should be careful when we are very close to such structures. When there is intraelectrode distance below 5 millimeters, we should be careful because current density, even at lower powers, can be so high into the tissue that it can result in some kind of complication. When there is an intraelectrode distance above 20 millimeters, I think that we can be out of range of bipolar ablation when we have such an intraelectrode distance. But when to think of bipolar ablation? When patient is symptomatic, I always start to think about bipolar ablation if patient is after multiple ablation procedures which failed. When we do not find a perfect activation mapping, this can mean that the site of origin is, for example, deeper. When pacemaker is nowhere perfect, when we have similar activation times at completely different spots, for example, similar early activation at both sides of the septum. When there is a broad area of similar activation, this also can suggest that the site of origin is deeper. And one important factor is suppression without complete elimination during unipolar radiofrequency. This frequently means that we are pretty close to the site and all we need is just a slightly deeper lesion. And also one more sign during unipolar ablation when we experience morphology shift without complete elimination. So this is one of our earlier experience when we targeted LV summit PVC. You can appreciate that activation is quite similar at the distal and at the proximal rings of our ablation electrode, which is located in the great cardiac vein, and actually there is no early in the opposite endo. Nevertheless, bipolar ablation was ultimately successful in this particular patient. We treated 4 patients so far using this approach. We achieved a significant PVC burden reduction in all study patients and no VT recurrence in 1 patient. We were able to demonstrate a transmural lesion in all our subjects. And now we are conducting a multi-center experience using this approach, 15 patients so far, and we experienced no complication. You can see that here there is an early signal in the great cardiac vein and nothing early in the opposite endocardium. You can see that we start at relatively high impedance values, then it goes down, but it is pretty stable. And here they were able to deliver 1-minute lesion. But this approach is highly dependent on anatomical factors. It requires great cardiac vein mapping. It requires safe distance from coronary arteries. We should be able to target at least 20 watts. We should aim to deliver at least 1 minute of application, and we should operate at impedance below 300 ohms. If we are unable to provide such conditions, we can think of nearby an anatomical structure, which is the left pulmonic cusp. You can see here in LEO view that it is very close to this catheter located in the anterior intraventricular vein. Here is another projection, aerial view. You can see that both catheters are very close to each other. And we also decided to combine this approach with bipolar ablation. You can see that the intra-electrode distance was approximately 18 millimeters, and there was very similar activation, nothing spectacular actually, at both these sites, and this patient was treated successfully with. This is our study in which we used such approach. You can see that in the great cardiac vein, you have only a early far field signal, but there is nothing early in the left pulmonic cusp, and there was nothing early in the left ventricular outflow tract in the subaortic region. But ablation in this patient was successful, and as you can see, we achieved a significant ventricular arrhythmia burden in all of these patients and also without VT recurrence in patients with VT. But we should be careful when we apply bipolar energy in close proximity of coronary arteries. Here is an example from the recent study which shows occlusion of the coronary artery. This was in the setting of myocardial bridge, which can conduct our radiofrequency current, and we should be aware of it. And this is actually a paper which shows that the way we should not perform our bipolar ablation. Here they used 50 watts for 60 seconds. The effectiveness of such approach was rather moderate because the lesion depth was approximately 10 millimeters. And despite this, they experienced above 15% of steam pops during their application. Here is an example of a steam pop in a healthy myocardium. I think we should be aware of this complication in cases when we try to ablate a healthy myocardium which is not protected with a scar. And actually, in our experience, minority of patients required high power ablation. Here is one patient from our study. Some patients required energies between 40 and 47 watts, and vast majority of patients actually underwent ablation at the level between 20 and 40 watts. Here is another study from Professor Della Bella when they used powers of 33 plus minus 4 watts. And tip to distance was 13 millimeters. So this is another suggestion that we should try to at least start with moderate powers. If we fail using standard application times, perhaps we can think of prolonging our lesion. Here's an example when we have elimination of arrhythmia after 30 seconds. So sometimes it is worth to just wait without up-titrating power to high power values, just using moderate powers, and prolonging your applications can do the job. The situation is a bit different when we deal with substrates related with scar. Scar protects our targeted tissue, and actually the temperatures are lower within the tissue when we ablate, even using high power values. So it acts kind of protective against steam pops, but this will mean that sometimes we'll require higher powers to deliver enough energy. Here is an example from Professor Sauer's group. They operated at levels between 50 and 70 watts in their study. They did not experience any complication related with bipolar energy delivery. Here is one of our cases when we dealt with basal septal VT. You can see two catheters, and you can see a bubble storm originating from the distal tip of the catheter we used as a ground. This is because of overheating. We exchanged this 4mm tip catheter to 8mm tip, and we continued our applications without problems. What can we do next? Well, we can think of using different coolant. Normally we use normal saline, which contains a similar amount of ions as our targeted tissue. This means that actually, because resistivity of blood is lower, this will mean that majority of current goes to the blood and some of the current goes to the tissue, and this results in lesion formation. We can upgrade this by using house normal saline, which contains less ions, and it allows us to deliver more amount of energy, which will go to targeted tissue. And ultimately, we can use dextrose 5 in water, which contains almost no ions. And when we use such irrigation, this will mean that majority of radio frequency will go to our targeted tissue. We treated 2 patients so far. These are 2 patients from our study I showed before, and both these patients experience a significant drop in their arrhythmia burden, and we did not experience any complication using such approach. Sometimes impedance values are very variable. We start at relatively high impedance, then impedance goes down for 50-70 ohms, and after lesion is completed, the impedance can actually go up above 300 ohms. So with this approach, we can experience a variable impedance values. And this is one example how bipolar ablation can be safely performed even in close proximity of fragile structures. This is our study dealing with ablation in close proximity of his bundle. You can appreciate that here on this catheter, we recorded a clear His signal at the proximal rings of ablation catheter, and the second catheter, we could only see their far-field signal of His. Despite this, radiofrequency ablation in this particular patient was successful, and there was no complication, no persistent AV block in this study. So if we uptitrate our energies very, very gradually, we can deliver a safe lesion even in a close proximity of fragile anatomical structures. So conclusions. Bipolar ablation can be safe and effective with a few precautions. We should know what kind of substrate we are dealing with, if it is a scar, if we are close to the crucial anatomical structures. It can be more effective for deep substrates. It can be really selective, and sometimes high power can be necessary in the setting of a scar. And there are many possibilities for future optimization of our setup. We can use different catheters, different coolants, and probably in the future we will be able to use more advanced bipolar ablation tools. So thank you for your attention.
Hi from ICAM. My name is Dan Wichterlem and my co-moderator is Robert Čihák. I see three presenters, Pasquale, Fermin, and Piotr. Hello.
Good afternoon.
I can't see Miguel. But we may start with questions for Fermin. There are a couple of them.
Yes. Thanks, Fermin, for nice talk. Do you notice any EKG pattern that suggests you for intramural origin of the PVCs?
Yes. First, thank you so much for the invitation, and I hope everything is going well for you guys there. Very nice meeting so far. So it's an interesting question. I think that we look at all our cases. There's no specific pattern for intramural. I think it's going to be the same type of pattern that we had for when we called it LV sum, and it's going to be an LVOT type of PVC or VT. You might have that, transition in V3, kind of pattern break in V2. What you don't see, it's Q waves. There's usually no Q wave in V1 and V2. There's always a small R wave. Besides that, it's inferior axis and usually to the left side of the midline, so more negative in AVL than AVR. And that's it. There's no specific signature pattern that we have found. There's a lot of overlap with other types of LVOT PVCs. I think that this is just an area. So the way we like to think about it, it's, if it doesn't look LV summit epicardial, it's not wide, there is a small R wave in V1 and V2, then we focus on this as an area rather than in a specific spot for a signature pattern. And then with that, we direct map into the areas as we described.
Okay, there's another question for you. Is there any experience of burning intramurally through the mapping wire? Yeah, I personally do not have experience with the wires we use. It didn't work because they're not good enough. I know that there is a published case from Romero and UCLA that they use one of these, the wires to cross chronic total occlusions, and they use that wire. But with these bipolar catheters and with the wires that we have, there's not been experience yet. I think that's probably going to be the best option in the future, because you limit the damage on the tissue and you can limit the size of the lesion to the perfect spot. So I think that's where we're going in the future, hopefully. But at this point, there is no, I am not aware. I don't know if the other presenters are aware, but not clinically available. There is no way to deliver RF right now for patients. And one other question that's for you, or maybe for other presenters. Do you routinely perform coronary viewing in the ablation procedures from coronary sinus?
I will let the others also answer, but what I do for all the cases is what I describe in my lecture. I think that the practical approach is start always the same, and then obtain the information, analyze if it's early in the endo, if it's early in the epi, or if it's early intramural, and then design your ablation strategy. I do exactly the same thing for every patient. I don't skip steps. I always do the same.
My first step is put coronary sinus catheter. I map the epicardium in the AIV and the gray cardiac vein. Then I put it in the intramural space, and then I map RVOT, and then I map LVOT, and I obtain the information, and you know right away. If you're early 45 milliseconds in the AIV, this is subepicardial, and you should now finish your mapping, but you know already what you're dealing with. So it's an approach in which I do the same thing for every patient every time, and that's how you get used to it. It becomes very fast, 10 minutes usually. It all depends on the anatomy, of course, but I do the same thing for every patient always that suggests LV outflow tract origin of the PVC.
Okay.
I have one more technical question to Fermin, and the last question for him. What is your strategy for ablation at sites with high impedance and low cooling, like in a distal vein branch? Or
yeah, that's the main limitation for ablation within the venous system. There's not much you can do, to be honest. I have tried different things, like inject more saline to dilate the veins. Our approach, I think, for example, tachycardias, it's a smaller tip and it's round, so it tends to have better impedance. And then we switch to half normal saline. You have to turn off the limit on the ablation console and let it go up, and then start lower. Just start like at 20 watts and then go up. But there's not much else you can do. It's always going to have high impedance. And you can just deliver sometimes very little RF there. There's not much to do. We think that half normal saline here is very useful. So we always switch to half normal saline. Besides that, we have 2 patches on the body. We place the patches closer to the chest. All these things to try to gain a little bit of room with impedance. But besides that, there's not much you can do.
yeah, thank you. So we should move to next presentation, which was given by Miguel. Hi, Miguel. And hi. I think there is at least one question. Maybe we will have more.
Do you see complete AV block with alcohol ablation? Miguel,
no, I have not seen it. We have, the worst we have seen is what I showed in this case, this recorded case, transient right bundle branch block. And that's been about it. I have not seen it. And that's kind of an interesting anatomical question. Why do we, I mean, I would have expected it more. I was some concern. First time I did alcohol in a septal vein, that was 2011. And I was very concerned about that. In fact, I had consented the patient for the eventuality of AV block, but I have not seen it. I think it's just much higher in the septum, and it's not in the membranous septum where the alcohol gets delivered to. So no, the worst that I have seen is only transient right bundle branch block, like in the case that I showed.
Okay. What's the amount of alcohol you use? Is it similar as for martial vein ablation, or it's more?
The amount, I've been a little bit more liberal with time. The first time we did 1 cc, and when you're in the place, when they're in the right place and your wire signal is 45 milliseconds pre-QRS or something excellent, and the alcohol is not being shunted by other veins, you get it in the first one. The problem is that mechanistically, the alcohol is being delivered retrogradely, and the antegrade flow is continuously competing with you. And when you give the first alcohol, you basically blow up the capillaries there, and you make the second alcohol delivery more efficient. So one thing we have learned, that even in cases where we had a spectacular response with the first injection, that that patient recurred and we had to deliver alcohol the following day. I repeat the whole thing. And what we know now is that I like to deliver at least 4 injections. And you can see when you inject contrast after consecutive injections that you get more staining. So each injection kind of improves the delivery of the following one. Now you want to stop at some point. Obviously, you want to limit the lesions. But clearly for a given spot, I've been given a minimum of 4 cc's.
Okay. And a question for Miguel.
One more question to Miguel. What is your strategy for ablation at sites? Are there any configurations that are not suitable for alcohol ablation? I can imagine if you find the earliest activation at, let's say, branching of relatively large veins, if it is not deep inside myocardium, there is no option for double balloon technique or.
So again, the suitability of this procedure depends on the anatomy, and there are situations where we shied away from giving alcohol. One very common is when you get the earliest signal in the very beginning of a septal branch. So you put your EP star catheter, your octopolar deep in a septal, and it turns out that the best signal is right at the very beginning of that septal perforator. Then it becomes really hard to make sure the alcohol gets localized to that portion of the very beginning of that septal. You can sure block that septal with a balloon, but then how do you inject it? It can be hard. Sometimes there are collateral flow that will shunt the alcohol somewhere else and you can't deliver it. But in general, pretty much once you get to deliver a balloon in a septal branch or intramural branch where you get a good signal, I've been giving the alcohol. It doesn't, sometimes you get complete success. Sometimes, 20 minutes after the PVCs come back and you reinforce the lesion with ablation. But other than anatomical considerations, this can be delivered. And the double balloon, in my experience, has allowed us to be more flexible. It's very interesting that the first time I delivered double balloon was in an ischemic VT years ago, 2015. But then the first time I actually delivered double balloon was in Prague a few years ago. We had a very big septal. We got a beautiful signal in the middle of it, but then distal in that septal there were huge branches, so we blocked. And we got success. Then the PVCs came back. Then we reinforced with radio frequency. It's a kind of a game here, but so not always is perfect. But for the most part, if you get a good signal, I deliver alcohol.
Yeah, thank you. And there is one more question, which can be probably answered by Miguel as a last question. How do you advance the agilis? You probably don't use agilis, but how do you advance the agilis deep into the great cardiac vein, by wire and dilator or via an EP catheter? It is probably in terms of safety.
I use agilis or probably whatever cheaper. I don't think the flexibility is necessary, or it's useful, but I don't think it's crucial. You put a wire, obviously, and the problem there is that what I advise, I want to make sure it's not about the question about the agilis, but I advise against putting a balloon occlusion distal in the CS because it's very easy to dissect. Balloons work well in the proximal CS, but once you go into the great cardiac vein and AIV, and if you inflate, it's very easy to dissect. But with a wire, agilis can go anywhere. And Fermin has more experience with agilis. I don't use it routinely.
Yeah, so we basically just use the agilis itself with the wire that comes in the agilis. You don't need a dilator. You don't need anything stiff. You just clock and then clock again. And then the reason we use agilis is not because the steerability, it's because of the size. So you can put more than one catheter. And so, for example, if you want double map, you can put a 4 French and a 3 French, or if you want to do more mapping, or it's because you can advance more than one catheter. And that's why we use agilis. You can use a cheaper LAM 90 or whatever sheath you have in yours. But agilis, just with the wire, no dilator, no ablation catheter. It just goes right in. So Miguel, one question. Are you doing this as your first strategy for everybody? No RF?
So I don't know if you saw the case that I
yeah, I did.
Case.
I saw it.
So listen, if I map the veins, if I see 45 milliseconds in a pre-QRS in a septal vein, I don't go RF in the endocardium.
Why not?
Anywhere.
If you're right opposite to it within half a centimeter,
Well,
and
I was trained to ablate where the lesion is best, and I still believe that paradigm.
Yeah, but a huge lesion is not best. A huge septal infarction is not best. I disagree with that.
You have, let me ask you, so you have an assumption there that ablation by crossfire from RV and LV and AIV is a small lesion. So I would challenge you to show me data. I would challenge you to show me data on the size of ablation by alcohol compared to the size of ablation by multiple site radiofrequency. You don't have the data.
I didn't say multiple sites. I say one site. Just one site opposite, like my case, one lesion opposite to the earliest wire, even if you're late. One lesion, no multiple lesions. I'm not arguing that. Your case.
You showed ablation from the AIV as well. So you're combining.
No. My last case is just endocardial ablation. No, Miguel. It's just one lesion opposite to the earliest side at -45, even if you're late. And the wire in echo is within half a centimeter. No, I'm not saying the ones that you have to ablate from everywhere. That's a different
Do you have data on let me just say one thing. I share the concern that you have, and we are gathering data on the size of the ablation by MRI. Currently, there's no data on MRI on multiple ablations by RF, on RV endo, LV epi, AIV. So I don't have a standard of care to compare it with. But I will gather the data and I'll show it to you, and then you can make your judgment. But you have made your judgment.
You include just ablation from the endo, one lesion. I'm not saying multiple targets. One burn opposite to the earliest site. I'm not saying multiple targets. You keep saying multiple targets. I'm saying one site opposite to the earliest site. I saw your case
how you did that, and then you went to the AIV.
No, the last case. No. That's because that's a true epicardial. I'm talking about my third case. That only from the endo. Okay. No, that's not right. You didn't see then my last case.
Guys, sorry to interrupt you.
Let's just talk about alcohol. I think you have made a judgment on the alcohol ablation size without data, and I will work on providing it. Okay. That's all I can say.
Guys, thank you. Nice discussion, but we should move to next presentation. Unfortunately, there are no questions to Pasquale from audience. Is it right?
Yes, that's right.
But at least I have one question. Clearly, multipolar mapping is predominantly used for activation mapping. But if we want to display voltage in traditional setting, like we use for mapping with regular catheters, with this for VTs 0.5, 1.5, what we should use when we are mapping, let's say, by AcuNav or DecaNav and or Pentarray. Is there other settings or how to adjust?
No, that's a great question, Dan. Thank you, first of all, for the invite. I don't think we have data that shows what is the optimal cutoff for every single catheter. In fact, when we use those, we try to match the voltage cutoff in the individual patient, what we see with pre-procedural imaging or what we see intraprocedural with eyes. And you'll see that every patient with every catheter that you use, the cutoff that you're going to end up using is a little bit variable, because the 0.5 to 1.5 only applies to the thermocool platform, 3.5 millimeter large tip. So for the smaller electrodes, I mean, there are some data here and there, but the voltage changes so much regarding on the type of electrogram, type of catheter, wavefront of activation. I've been working mostly, honestly, on inactivation now to look at just subnormal electrograms. They've been pretty much abandoning the voltage. The unipolar, we have some data we haven't published yet. The unipolar doesn't change much. The unipolar voltage, because you're referring to the Wilson central terminal. So that doesn't change with multipolar versus single tip catheter much. But bipolar, there is a huge change in voltage. That's why we've been working mostly with activation and mostly by looking at the slow conduction with abnormal split and late potentials, lavas, etc. That's the way we use these catheters mostly, and we don't really work in voltage. But
okay, if you have patient with not ischemic cardiomyopathy, do you always start with simultaneous endo and epi mapping, or you start only with endo and epi in the next procedure?
So we try to characterize the patient either pre-procedure when possible or during the procedure. There is about at an institution, 60% of non-ischemics have an anteroseptal substrate, which is mostly intramural and localized in the anterior wall close to the aortic annulus. In these cases, we do not go, we used to go epicardial, but we haven't found any targets really. So we don't go epicardial any longer. And these patients are characterized typically that sinus ECG shows some form of conduction abnormality, usually a left bundle branch block or conduction system disease, and have inducible left bundle or right bundle inferior axis VTs. And usually if you have an MRI, you see a septal scar, or you can also use transseptal conduction, etc. This again is 60% of our population, which we do not go epicardial. The remaining 40% have basolateral involvement of the left ventricle, the free wall, or the right ventricular involvement. In those are in that specific type of VTs, right bundle, superior axis, typically with an intermediate axis, occasionally negative lead one. And you see on intracardiac echo wall thinning usually of the free wall of the left ventricle. In those cases, we do go epicardial. Not necessarily up front though, because again, sometimes you can achieve non-inducibility also by targeting the endocardium. Of course, if you find a normal voltage, by voltage, I mean normal substrate and activation in the endocardium and no good targets, we go right away to the epicardium. But very rarely we do it up front unless we know that has been ablated already by us endocardially and is recurred. And in those cases, we do epicardial up front.
And what's your typical settings for ablation? What energy do you use? There are some labs going up to 70 watts.
Yeah, we are limited in the US by FDA regulations to up to 50 watts. We cannot go up with our power. Q dot will be able to, although we'll be still limited at 4 seconds, anything above 50 watts. So our target is always up to 50 watts. We do use a lot of impedance. We look at impedance trend, but use a lot of intracardiac echo. We found that really extremely helpful to predict the areas of potential stim pop even more and before impedance rises. So typically our settings, at least my settings, in scar-related VT, I very rarely ablate below 40 watts and I modulate between 40 and 50, but I try to stay for longer time as opposed to short duration. So typically we do non-ischemic 2 to 3 minutes point lesions at the site of interest. For ischemic, usually we do 90 seconds to 120 seconds, depending on where we are and the location. We do not use, of course, high power short duration in the ventricle because it doesn't make a lot of sense. And that's not the reason why most of the substrate needs to be targeted with longer lesions. But yeah, that's our set, at least my settings. I don't know if Fermin has different ones, but I think it's consistent.
Okay, is there any other question for Pasquale?
Probably last question about HD grid. I have no experience with HD grid, but I can imagine to map with this device or mapping catheter in left atrium, right atrium. But how about ventricle? Is it difficult to manipulate in the area of papillary muscles and so on?
It's actually not that difficult. I would say, at least in my experience, it's actually easier compared to other form of multipolar like the spline catheters and Pentaray. First of all, there is not much chatter between different splines because the electrodes do not touch each other. So the signals are a little bit better. And the catheter has got a very long reach because what they've done with the HTG, they attach the grid on the tip of the flexibility catheter. So you effectively end up with a catheter that is a longer reach. It's very easy to map. And I have to say it's easier to map the base than the mid-apex, like any multipolar catheter. But I honestly haven't found any issues with manipulation in the ventricle. And usually I use the HTG transseptally and I can reach pretty much all the areas. Of course, if you have a small ventricle with an idiopathic VT, I mean, in those cases, any multipolar catheter is terrible because I mean, there's a lot of ectopy and the ventricle is contracting against you. But if you have a nice defined substrate, HTG does work fairly well.
All right, thank you.
Okay, we can move to Piotr Futyma presentation. There is one question. Left pulmonary cup is close to left main and LAD. Would it be a concern for bipolar ablation there?
Well, yes, absolutely. That's why we should take our time to manipulate the catheter properly, to put it as low as possible. you can estimate the exact distance to LAD by performing, for example, ICE. So you can have like a live view where you are and how far you are from the LAD. Another option is to put a CS catheter to have a landmark, which is usually at the level of LAD. So once you are stuck in the distal CS, you know exactly where LAD is, and you should try to put your catheter as far in the cusp as possible. And of course, you can shoot coronary angiogram and to estimate the target. And this is how we started. We started with almost live coronary angiograms to be sure that we are in a safe distance. Recently, we did a case with ICE, and it was really useful to estimate the distance between the catheter tip and LAD. Another option is to perform transluminal angiogram. It will show you that you are at the bottom of the cusp, and usually if you are at the bottom of the cusp, this means that you are in a, let's say, decent distance from the LAD.
You mentioned several indications for bipolar ablation. What about hypertrophic cardiomyopathy, and if you want to destroy septum, if their alcohol ablation is not successful?
Well, I think we are quite far away regarding catheter design at this point, but I'm pretty sure that once we get larger surface area of the catheter, then perhaps we will be able to perform septal ablation, bipolar ablation in hypertrophic patients. I think I do not have personal experience with that in clinical setting, but I think that large tip electrodes, 8mm tip catheters can be particularly, let's say, promising option for these kinds of patients if somebody decides to perform bipolar ablation using in this setting.
I have at least one question. Your topic today is LV outflow tract ablation, or RV-LV. Do you use the bipolar energy or bipolar setting in other regions like RV-LV or at the atrial level?
Yes, absolutely. The LV summit is most common approach for me. The other option is perhaps this can be a surprise, but we have quite a large number of patients treated who had their ectopy close to the bundle of His. And of course, you need to titrate your energy very carefully and track any junctional activity there. But it can be done. It's not an atom bomb you drop on the intraventricular septum close to His. I think it can be pretty well controlled. So this is also an option for the septal substrate without the mandatory AV block.
All right, thank you. And what about, for example, resistant mitral isthmus line to ablate bipolar? Because we did one case a couple of years ago. It was first in human experience, and it was successful. Do you have any?
Yes, well, it was basically the initial concept for the radiofrequency ablation. The first lateral WPWs were performed in bipolar fashion. Of course, there were some significant limitations those days, no open irrigated catheters. So I think this approach is particularly related with anatomy, and because sometimes the coronary sinus is so small that actually your ablation catheter is stuck there, and it does not allow you to deliver enough energy.
All right, thank you. And last question. I understood that you prefer to use the 2 irrigated catheters. What is the indication for usage of 8mm from one side? What is this?
Well, to be honest, I switch to 8mm when I require higher powers. And basically, if you have a scar, it will protect itself against your radio frequency, even if you use bipolar ablation. So at some point you might require higher energy values, let's say 50 watts or even above 60. There are some papers that describe the use of 70 watts in the setting of 8mm tip catheter in bipolar configuration. So if I require higher powers, then perhaps I may decide to use 8mm tip catheter in this setting. Another interesting option is to put an 8mm tip catheter in the coronary sinus, because you will have lower system impedance. So this can actually, let's say, promote conductive heating in that area from the coronary sinus. This can be another option.
All right. It was the last question. I should close, or we should close this discussion panel. Thank you so much to all presenters for nice presentations and very nice discussion. And hopefully see you in person, maybe next year or in Prague. Thank you.
Thank you very much.
Goodbye.
Bye-bye.
Thank you, everyone. Thank you. Bye-bye.